To all my friends studying for USMLE Step 2, here's a question that could easily show up on your exam. We have a case of a 72-year-old woman who presents with 8 hours of crushing chest pain, shortness of breath, and some dizziness. Her vital signs show a blood pressure of 98/60, a heart rate of 120, and oxygen saturation of 92%. On examination, we found an elevated JVP, bilateral crackles, S3 gallop, and mild leg edema. And he's asking, what's the diagnosis? Is it A, aortic insufficiency, B, papillary muscle rupture, C, cardiac tamponade, or D, cardiogenic shock? Now pause for a second and try to think of an answer. Okay, so the answer is cardiogenic shock. Okay, and instead of memorizing it, I want to show you how to actually understand it using this diagram. Let's call this diagram the diagram of cardiogenic shock. We're going to start by drawing the left side of the heart, the right side of the heart, both lungs. Here you have the trachea and the tracheal rings, 2 lungs and the trachea. So basically everything starts here on the left side. When the left side of the heart fails, most commonly due to an MI, the cardiac output drops. Another name for cardiac output is cardiac index. You could find this on your choices. And so, the cardiac output drops, the cardiac index drops, and the patient becomes hypotensive. But the blood doesn't just disappear, right? It backs up into the lungs, causing an increase in the PCWP, also known as the left atrial pressure. This is going to clinically show up on the patient as pulmonary edema, crackles, and severe dyspnea. And the backup continues. So all the way to the right side of the heart, the CVP increases and the JVP increases. Clinically, it shows up as a distended neck veins and lower limb edema. Meanwhile, the body tries to compensate by increasing the systemic vascular resistance, giving you cold skin and cold extremities. And so cardiogenic shock gives you low cardiac output, high pulmonary capillary wedge pressure, high CVP, and high systemic vascular resistance. And if you want to take it one step further, the cardiac index is low. Sometimes you could get this as a choice. And also something called the SVO2 is low. And this is because when the oxygen delivery to the tissues is poor, tissues are extracting more oxygen. So the venous oxygen will be low. The final line, when the heart fails, the blood backs up and the perfusion drops. And the numbers tell the whole story. Now let's quickly eliminate the wrong answers, okay? Aortic insufficiency, yeah, it could cause pulmonary edema, but instead you would hear a diastolic murmur, which is not present here. Number 2, papillary muscle rupture can happen after an MI, okay, but it would cause acute mitral regurg, and that would cause a loud systolic murmur. This patient has an S3 gallop and not a murmur. Number C, cardiac tamponade, yes, it could cause obstructive shock, but it would cause the classic triad of hypotension, increased JVP, and muffled heart sound. Here we have an S3 gallop and not muffled heart sounds. So remember this for the exams. Post-MI plus hypotension plus pulmonary edema, this is usually a cardiogenic shock.